This is Dr. Aditya Sibichakravarti from Dr. Talks. Today we will be seeing our second lecture in rheumatology series, that is rheumatoid arthritis. This rheumatoid arthritis is one of the most common chronic inflammatory arthritis that is prevalent in the world. It is more commonly seen in an young female population. 20 to 40-year-old females, they are more prone to develop this rheumatoid arthritis. The prevalence of rheumatoid arthritis increases from 20 to 50 years, then it reaches a plateau and then comes down after 75 years of age. So how does rheumatoid arthritis present? So what is the arthritis in rheumatoid arthritis? It is usually a bilaterally symmetric arthritis predominantly involving the small joints of the upper limb, especially the metacarpophalangeal joint, the wrist joint, the metacarpophalangeal joints, the proximal interphalangeal joints. They are the ones that is most commonly involved. It is an arthritis where the patient complains pain with swelling, with decreased mobility, with tenderness, with redness. This is what is an arthritis. An arthralgia means just a pain. Here there will be pain with the evidence of joint swelling, with evidence of tenderness, with decreased movements. This is what is classically the arthritis. This rheumatoid arthritis can present with early morning stiffness of at least 30 to 60 minutes will be present, and they can have polyarthritis. Polyarthritis means there is multiple joint involvement. Monoarthritis means single joint involvement. Oligoarthritis means less than 10 joints involvement, and polyarthritis means multiple joints involvement. This polyarthritis will be erosive. There will be evidence of joint destruction and cartilage destruction and erosion that will be seen in rheumatoid arthritis. So how do you classify this rheumatoid arthritis? This rheumatoid arthritis can be classified into three groups. Those with the early rheumatoid arthritis, established rheumatoid arthritis, and chronic rheumatoid arthritis with all these complications. So why we have to classify this rheumatoid arthritis into three groups is that early intervention with aggressive immunosuppressions and disease modifying agents, if it is given very early, before you develop all these contractures, that can cause the reversal of the underlying problem. Once the patient develops this contracture, there is no point in giving all these DMARDs because joints are already damaged. You can treat it for the extra articular manifestation, but the damage has already been done. So we have to pick the patients early. Any patient, when even with early inflammatory arthritis, early undifferentiated arthritis means there will be less than one or two joints, only one or two joints will be involved, but the patient can have this significant arthritis, pain, swelling, tenderness, decreased joint movement, redness. If those patients should be examined for the presence of the antibodies, anti-CCP and RA. If you think the patient is to be an established, pre-rheumatoid arthritis, you have to start the patients on disease modifying agents as soon as possible, because it will prevent the progression into severe disease. As we said that early and differentiated arthritis is the first 3 months, established rheumatoid arthritis between 3 months to 2 years, and chronic rheumatoid arthritis after 2 years there is a formation of deformity. So what are the deformities which are classically seen in rheumatoid arthritis? The first one will be the flexor tendon tenosynovitis. Because of the flexor tendon tenosynovitis, the patient can develop problems like trigger finger, or there will be difficulty in having a grip of the fingers. That will be seen secondary to flexor tendon tenosynovitis. And what is the Swan neck deformity? The Swan neck deformity, there will be a flexion of the distal interphalangeal joint and hyperextension of the proximal interphalangeal joint. This is Swan neck deformity. And botinus deformity, there will be flexion at the proximal interphalangeal joint and the hyperextension of the distal interphalangeal joint. This is the botinus deformity. In Z-line deformity, there are zigzag deformity. There will be radial deviation at the wrist joint and ulnar deviation at the metacarpophalangeal joint. This is the Z-line deformity. Piano key deformity is not actually true deformity. It is secondary to ulnar styloid process inflammation and rupture of the extensor carpi ulnaris tendon. These are the common deformities in the upper limb. In the lower limb, it first involves the metatarsophalangeal joint. That is the one which is first involved in the lower limb. Later, it can involve the ankle joint and the mid-tarsal joints, and resulting in the flat foot deformity. The other joints which can be involved will be the C1, C2 joints, resulting in atlantoaxial subluxation. This atlantoaxial subluxation can result in cervical myelopathy, which can be very serious if untreated. Then we can also involve the rheumatoid process can involve the temporomandibular joint, causing difficulty in opening and closing the mouth. So these are the deformities that can be seen in rheumatoid arthritis. So what are the extraarticular features of rheumatoid arthritis. So who are the patients who are at high risk of developing extraarticular manifestations? Patients with high titers of Ig, rheumatoid factor and anti-CCP antibodies, patients with very aggressive, early onset aggressive involvement of the joints, patients with evidence of vasculitis. These patients are more prone to develop extraarticular manifestations. The first we will see the constitutional symptoms. These constitutional symptoms are highly non-specific and can be seen in any patients with rheumatoid arthritis. They include fever, myalgia, arthralgia, malaise, fatigue, weight loss, cachexia. These are the normal constitutional symptoms that is present in rheumatoid arthritis patients. Then rheumatoid nodules. This rheumatoid nodules, the presence of rheumatoid nodules means the patient is having significant as well as severe underlying rheumatoid arthritis. It means that patient is having very severe destructive rheumatoid arthritis. They can be present at the periosteal elevation. It can be present on the surface of the bones. The differential diagnosis will be the nodules that is present in acute rheumatic fever or SLE nodules. So these are the second differential diagnosis. Then Sjogren's syndrome. Rheumatoid arthritis patient can have complications like dry eyes, dry mouth, like Sjogren's syndrome because of overlap, or they can have this manifestation. Then lung manifestations. They can have pleuritis with or without pleural effusion. This pleural effusion, this patient can manifest with chest pain, a pleural type of chest pain with difficulty in breathing, with a pleural effusion that has got exudative character with high neutrophils and macrophages. They have very low glucose. This is the catching point. Very low glucose is one of the manifestation of rheumatoid arthritis pleural effusion. What are the other pulmonary manifestations? The patient can develop interstitial lung disease. We have dealt a separate topic on interstitial lung disease where we have clearly told that rheumatoid arthritis ILD is more common in male population than female population, and rheumatoid arthritis ILD is predominantly usual interstitial pneumonia than an NSIP pattern. All the connective tissue disorders have NSIP pattern except rheumatoid arthritis, which has got an UIP pattern. By UIP pattern I mean there will be involvement of the lower lobe on the posterior pleural area, and there will be loss of lung architecture, there can be traction bronchiectasis, there can be honeycombing, there can be cystic changes. All this finding can be there. If it is an NSIP pattern, there will be presence of ground glass opacities and with reticulonodular infiltrations. And pulmonary function test shows a restrictive lung disease with a decrease in the FEV forced vital capacity, decrease in the DLCO. This will be seen. The presence of ILD has to be managed with high dose steroids, and other DMRD should be given because it can be life threatening if not treated, but however with treatment it carries a good prognosis. The other lung manifestations include Kaplan Syndrome. Kaplan Syndrome is a triad of patient with active rheumatoid arthritis plus the presence of pulmonary nodules plus the presence of patient is having some silica exposure, inhalation of silica. These three triad forms the Kaplan Syndrome. The other rare one will be the presence of bronchiectasis or respiratory bronchiolitis, but they are very rare in rheumatoid arthritis. Cardiac manifestation. Pericarditis is the most common manifestation. It is seen in rheumatoid arthritis. This pericarditis seen in 20% clinically, but by echocardiography it can be seen in 50% of the patients. Then second finding will be the evidence of cardiomyopathy. Again, the cardiomyopathy can be picked up with, by 2D echo and cardiac MRI. The other finding will be in mitral regurgitation. This mitral regurgitation is the most common valvular heart disease in rheumatoid arthritis patient. Then the patient can have nodules involving the myocardium. The rheumatoid nodules can involve the myocardium and lead to cardiac failure. Then vasculitis. The rheumatoid vasculitis can manifest as petechiae, purpura. Patient can have venous ulcers, or a patient can have extremity ulcer, or the patient can, worst case scenario, there will be evidence formation of peripheral vascular disease. These findings can be seen. The presence of vasculitis is usually seen in a patient with high disease activity. They will have high anti-DSD, high anti-CCP, high RA factor, raised ESR, CRP, low complement levels. Such patients only will have this vasculitis, and it is very significant. They can also develop livedo reticularis like finding can also be seen. Then blood findings. Anemia. Anemia is the most common manifestation, most common blood manifestation in patient with rheumatoid arthritis. This anemia is secondary to anemia of chronic disease. It can be associated with raised ESR and CRP. The platelet count is usually will be increased in rheumatoid arthritis. Immune thrombocytopenic purpura is very rare in rheumatoid arthritis. Then there is a condition called as Felty Syndrome. What is this Felty Syndrome? It is a triad of neutropenia, pulmonary nodules plus prevalence of neutropenia, pulmonary nodules and splenomegaly. It is a triad of these three findings. This Felty syndrome has to be differentiated from the T cell large granular lymphocyte leukemia should be differentiated from Felty syndrome. Two findings. Felty syndrome will be seen in advanced disease and it is a late manifestation, and the large granular lymphocyte leukemia is an early manifestation. Again, this kind of neutropenia and splenomegaly, but this also has got neutropenia and splenomegaly, and the clinical manifestation has got similar in both these conditions. Then lymphoma. Lymphoma is present as a fourfold high times than RA patient than a general population, especially the diffuse large B cell lymphoma. That is more commonly prevalent in rheumatoid arthritis patients. So, what are the hypoandrogenism? Hypoandrogenism is seen in male population as well as in postmenopausal female population. This hypoandrogenism can be because of the systemic inflammation leading to decreased androgen, decreased dihydroxyepiandrosterone. The patient can have decrease in the follicular FSH and LH. Also, the chronic steroid use also will decrease the FSH and LH. They can also lead to secondary decrease in the androsterone. They can present as impotence in male and osteoporosis and may require for androgen replacement. Then osteoporosis. Osteoporosis can be because of three reasons. First, the patient that can be because of systemic steroid use that can cause osteoporosis in the bones. Then because of the chronic disuse, because the functional disability of this deformities can lead to bone resorption and osteoporosis, or it can be because of the underlying inflammation from the joint spaces. It can involve the generalized osteoclast activation and it can go for osteoporosis. These are the three common findings. And the renal manifestations. Renal manifestation will be either membranous nephrotic syndrome or the patient can develop renal amyloidosis. So what is the natural history of the disease? The patients with rheumatoid arthritis, 10% of the patient can go for either spontaneous remission within 6 months of disease activity. The other group can develop as a slowly progressive waxing and waning course and slowly progressive worsening and formation of established rheumatoid arthritis. The other population can, the patient can have acute exacerbation and then the patient will be asymptomatic for a long period of time, then another acute exacerbation. So that is the third group of patient. And fourth one will be the very highly aggressive group where there is quick development of severe rheumatoid arthritis, severe deformity occurs very rapidly. These are the four natural groups. Basically, they have got a higher mortality rate than general population. Rheumatoid arthritis patient have got a higher mortality rate, especially because of myocardial infarction, because of accelerated atherosclerosis. That is the most common cause of mortality in rheumatoid arthritis patient. So, how does this rheumatoid arthritis develop? There are certain genetic risk factors as well as environmental risk factors. The genetic risk factors are basically three things. The patients can have the first degree relative. If a patient is rheumatoid arthritis, his first degree relatives are more prone to develop rheumatoid arthritis. That is the first risk factor. Second is an HLA-DRB1. This has got high risk of developing rheumatoid arthritis. 0401 has got very high risk of developing rheumatoid arthritis, and there are other alleles which have got a moderate or low risk. 0101. The other groups have low risk. Then PTPN22 gene mutation and patient with PADA4 mutation. All these patients are at high risk of developing rheumatoid arthritis. Then environmental risk factors, mainly four risk factors. First one will be cigarette smoking, then exposure to Epstein-Barr virus, patients with chronic periodontitis, or patient with P. gingivitis infection. They can also develop this rheumatoid fever. Both this genetic and environmental risk factor can lead to some immune dysregulation, and there will be activation of the antigen presenting cells. Because the antigen presenting cells are activated, this will activate the T lymphocytes, the Th1, Th2 and Th17, all the lineage gets activated. The Th17 activation can lead to macrophage activation with the release of interferon gamma. This macrophage will release TNF alpha. This TNF alpha is a major cytokine. This TNF alpha, what it does is that it will cause inhibition of osteoblast and activation of osteoclast. Inhibition of osteoblast and activation of osteoclast. How does TNF alpha activate the osteoclast? By increasing the rank ligand and rank interaction. How does it increases rank ligand rank interaction? It will inhibit the osteoprotogrin. The normal function of osteoprotogrin is to inhibit the release of rank ligand from the macrophages. Because the TNF-alpha will inhibit the osteoprotogrin, there will be increased release of rank ligand from this activated macrophage, and this rank ligand binds to the rank receptor and result in the activation of osteoclast. The end process of this will be osteoclast activation by rank ligand rank interaction and osteoblast inhibition by DPP4 pathway. So increased osteoclast activity cause increasing bone resorption. What happens pathologically? What happens to the joints? There will be synovial inflammation and there will be synovial thickening, synovial hypertrophy and the formation of pannus. This pannus is a collection of fibroblast, and then there will be multiple inflammatory cell infiltration. T lymphocyte, B lymphocyte, macrophages, B cells, plasma cells, mast cells, everything will be infiltrated in the synovium, and the synovium will go for enlargement. It will go for destruction of the underlying cartilage as well as the underlying bone. Then there will be release of growth factors from the fibroblasts and macrophages. This will cause neovascularization of the synovium. This will increase the blood flow as well as it will maintain this inflammatory cell infiltration to the synovium. Then secondly, there will be destruction of the underlying cortical bone. There will be thinning of the underlying cortical bone. This is the second finding. And there will be evidence of periarticular osteopenia. This periarticular osteopenia is because of the activation of the osteoclast and osteoclast mediated resorption. This osteoclasts are located at the junction between the pannus and the underlying bone. So this is the basic pathology that is seen in patients with rheumatoid arthritis. So how do you diagnose a rheumatoid arthritis? So first, the classification criteria. What is the need for this classification criteria? The need for classification criteria is to pick the rheumatoid arthritis early, and you have to go for aggressive management, thereby preventing the established or chronic rheumatoid arthritis. So it has got 4 categories. First one will be the joint involvement. Joint involvement, rheumatoid arthritis has to involve small joints. Then only can think in more in terms of rheumatoid arthritis. So the scoring will be 0 for a 1 large joint involvement. If the patient is having 1 to 3 large joint involvement, 3 to 10 large joint involvement, they have a score of 2. Or 1 to 3 large joint involvement, they have a score of 1. The patient is having 1 to 3 small joint involvement, the patient will have a score of 3. Patient having 3 to 10 small joint involvement, the patient will have a score of 4. If the patient is having more than 10 joint involvement, at least 1 small joint involvement, you have to give a score of 5. So you have to count the number of joints that is involved in patient with rheumatoid arthritis. That is the first thing. Second, you have to go for rheumatoid factor and anti-CCP. If there is a negative rheumatoid factor and anti-CCP, you have to give a score of 0. If the rheumatoid factor and anti-CCP are low positive, that is they are 3 times the upper limit of the normal, you have to give it a score of 2. If it is high positive, more than 3 times the upper reference limit, then you have to go for a score of 3. Then duration, less than 6 weeks means 0 points, more than 6 weeks means 1 point. If a total score is more than or equal to 6, then this patient is more prone to develop established rheumatoid arthritis. What are the lab findings? Lab findings, the patient with rheumatoid arthritis can have elevated ESR, elevated CRP, elevated rheumatoid factor and elevated anti-CCP. This rheumatoid factor can be either IgG or IgA or IgM, but this IgM is one which is measured more commonly. It is seen in 70 to 80% of the rheumatoid arthritis patient. Negative RA factor does not rule out rheumatoid arthritis, but it can also be seen in other conditions like SLE, Sjogren syndrome, HBV and HCV infections. Then it has got no prognostic value. Whereas an anti-CCP is more specific and sensitive for rheumatoid arthritis, and negative anti-CCP and positive anti-CCP means the patient can have more worse disease and more destructive diseases possible. Then synovial fluid analysis. Synovial fluid analysis will show an inflammatory arthritis. Inflammatory arthritis in the form of raised WBC. Non-inflammatory arthritis will have a WBC count of less than 2000, and inflammatory arthritis will have a WBC count more than 5,000 to 10,000. It will be more than that. That will be one finding, and there will be predominant neutrophil infiltration within the synovial fluid. That is the second finding. Then imaging. Imaging is very important in both in diagnosis as well as for follow-up of the patient. X-rays are the ones that is most commonly used clinically for the follow-up of patients. X-ray can show periarticular osteoporosis. That is the most common finding of X-ray. The other finding will be the soft tissue swelling. Then there will be joint space narrowing, and there will be evidence of bony destructions or focal bony erosions. This can be present. In advanced stages, you can go for joint subluxation, that can also be seen. Then MRI can early identify the presence of the synovial fluid. It can find synovial inflammation can be picked up in MRI. It can also shows bony erosions and bone marrow edema. This bone marrow edema can easily, or bone marrow inflammation can be picked up with MRI, and that case it can occur even before the onset of arthritis. Then ultrasound can also identify this synovial inflammation, and also can identify the increased blood flow to the synovium, which is an indirect indicator of inflammation. So how do you treat rheumatoid arthritis? The treatment of rheumatoid arthritis has undergone a paradigm shift. So the basic need to treat the rheumatoid arthritis is to pick the patient early and treat it with DMARD and aggressively prevent the disease progression. If the patient has established rheumatoid arthritis, then there is nothing much you can do. You can only go for symptom control and complication. The extra-articular manifestation has to be managed. But our main aim is to protect the joints. So NSAIDs, which was used in the past, is now not preferred in acute rheumatoid arthritis patients. They can be used as a additional add-on drug, but they cannot be given as a primary drug in rheumatoid arthritis because they can also have problems like gastritis and renal dysfunction. Hence, NSAIDs are not much preferred as a first-line management. They can be used as an adjunct for painkillers. Second one will be the steroids. Steroids can be used in 3 conditions in rheumatoid arthritis. First, the DMARDs, which are the treatment of choice for rheumatoid arthritis, they take some time to act. They take some 4 to 6 weeks to begin their action. So during this period, for an acute control, you can go for steroids. That is the first indication. The second indication will be if it is an aggressive high-grade acute exacerbation, acute flaring up of rheumatoid arthritis. In that condition, you can go for the steroids to control the suppression. Thirdly, if the patient is not controlled, disease activity is not controlled with DMARDs, you have to go for chronic low-dose steroids for this disease control. The problem with this chronic low-dose steroid is that the patients are at high chance of developing osteoporosis, because steroids can produce osteoporosis. So, any patient requiring chronic steroid therapy should be put under some calcium supplements, or you have to go for bisphosphonates or denosumab, teriparatide. These drugs can be tried if there is a risk of osteoporosis. Then DMARDs. These DMARDs are the treatment of choice in patients with rheumatoid arthritis. And the methotrexate is the DMARD of the choice. It has been used for a long period of time, and it has been very successfully used. It is used with a dose of 7.5 milligram on 2 days, on Saturday and Sunday. On the other 5 days of the week, you have to give for folic acid administration. This is the most effective first-line treatment in patients with rheumatoid arthritis. This cannot be used in pregnancy. Apart from that, in all other conditions, methotrexate can be used as a first-line agent. Along with methotrexate, hydroxychloroquine can be given. Hydroxychloroquine can be given at a dose of 200 mg BD. The problem with hydroxychloroquine is that it can cause irreversible retinal problems. So you have to go for fundus evaluation before starting HCQ in patients, and you have to go for QT monitoring also, because QT prolongation can also occur with hydroxychloroquine, and it can also cause liver damage and cardiac problems. Then sulfasalazine. Sulfasalazine is the other DMARDs. It can be used at a dose of 500 mg BD. All these 3 DMARDs can reduce the symptoms of rheumatoid arthritis. It can reduce the disease progression on rheumatoid arthritis, and it can prevent the advanced form of rheumatoid arthritis. So the triple drug regimen having the sulfasalazine, methotrexate and HCQ can be started in most patients with rheumatoid arthritis. Only when patients are not settled with these 3 drugs at a higher dose, even at a dose monitoring, then you have to go for the other drugs. Then leflunomide is also another DMARD, is given at a dose of 10 mg per day. It is a dihydroorotate dehydrogenase inhibitor. This can also be used as a second line DMARDs along with methotrexate. In pregnancy patients, especially in pregnancy, we cannot use this methotrexate. So we have to manage 75% of the pregnant female will actually have improvement during pregnancy, and only after delivery there will be worsening of rheumatoid arthritis. If the patient during pregnancy itself having an acute exacerbation, you have to manage them with either a low dose steroids along with hydroxychloroquine and sulfasalazine. Methotrexate and leflunomide are contraindicated. Hydroxychloroquine can be given, sulfasalazine can be given, and low dose steroids can be given in pregnancy. The other things is the biologicals. These biologicals can be started if the patient is not having good response with these DMARDs. First, we will start with anti-TNF alpha drugs. The anti-TNF alpha, there is 5 drugs in anti-TNF alpha inhibitors, namely infliximab, adalimumab, certolizumab, idanexor, golimumab. These are the anti-TNF alpha inhibitors. These drugs can reduce the signs and symptoms of rheumatoid arthritis. They can reduce the disease progression, and X-ray severity can be decreased with these drugs. But the problem with this drug is that they can cause significant immunosuppression, and they can have significant hepatotoxicity and nephrotoxicity. Because of this immunosuppression, there is high chance of opportunistic fungal infections, opportunistic bacterial infections. They can cause TB, latent TB reactivation. So you should rule out hepatitis B, hepatitis C and latent TB before administering these drugs, because they can worsen the latent TB infection. You have to go for rule out latent TB infection by either PPD injection, purified protein derivative injection, or interferon gamma release assay. They should be done. If the patient is found to have latent TB infection, you have to go for INH prophylaxis for 9 months, and the anti-TNF alpha inhibitor should not be given in such patients. The second group of drug will be the rituximab. Rituximab is an anti-CD20 antibody. It is again monoclonal antibody that is directed in the B cells. Rituximab can be used as an add-on therapy to methotrexate in patients who are seropositive who are refractory. Rituximab can be tried in such patients. Then the Docilizumab, the recent COVID miracle drug, basically it is an interleukin-6 antagonist. It can cause immunosuppression, significant immunosuppression. There is high chance of opportunistic infection with this Docilizumab administration. The patient can have neutropenia, thrombocytopenia, granulocytopenia. They can have liver enzyme abnormalities. So all these problems can be done. They can be tried as an add-on drug in these patients. Then the other drug will be the tofacitinib. This tofacitinib is a Janus kinase inhibitor, JAK2 and JAK3 inhibitor. By inhibiting the Janus kinase, it can decrease the production of multiple interleukins, 2, 3, 6. Multiple interleukins will be decreased. Because of that, it can be used as a combination therapy with methotrexate or with other DMARDs. It can significantly reduce the disease progression. Then abatacept. Abatacept is a fusion product between the CTLA4 and human monoclonal IgG. This can decrease the activation of T lymphocyte and as well as the antigen presenting cells by inhibiting the CD80-86 in the antigen presenting cells, and the interaction CD28-86 interaction, it will inhibit the T cell activation, but can cause significant immunosuppression and increased risk of infection. So this should not be combined with anti-TNF alpha inhibitors. Then anakinra is a recombinant interleukin-1 antagonist. This can be used in multiple conditions apart from rheumatoid arthritis, but in rheumatoid arthritis it is not much effective. It can be used in adult onset Still's disease or juvenile inflammatory arthritis. In this condition, this anakinra can be given. Apart from this thing, you can go for physiotherapy or surgical implants can be tried in refractory cases, but the efficacy is not much. Physiotherapy can be given for the pain relief. So, rheumatoid or any young female presenting with joint pain, swelling, inflammation, tenderness, if there is multiple small joint involvement, you have to think in terms of rheumatoid arthritis. Do an anti-CCP, RA and ESR-CRP. If the ESR-CRP and anti-CCP are elevated, you can think the patient has very early rheumatoid arthritis. Go for an X-ray. If there is showing any evidence of periodic osteoporosis, you can confirm it as rheumatoid arthritis. Start the patient on DMARDs very early. Predominantly methotrexate will be the preferential drugs. Look for all the you have to monitor the liver, LFT. You have to monitor the hepatitis B, HCV profile should be done, and you can add steroids or other HCQ or the sulfasalazine. These 3 drugs can be given as a early treatment. So this sums up our discussion on rheumatoid arthritis. I hope this was useful. I would like you to share your thoughts in the comment section. How was the discussion, or how did you find it useful? And I would like you to share this with your friends. Subscribe to my channel and click the bell icon. Thank you.